All right, if everyone wants to go ahead and turn their cameras on, we're going to go ahead and get started with class. Thank you. All right, how's everyone feeling after that? A little brain dead? We don't have too much class time left, so we are gonna use the full time this week just because we took our little break after the exam. So we are planning to go to like 8:11 or whatever it is. Um, so as far as when you will get your grades. Everybody, so everyone has to test and then we release the grades. So there's a class that tests on Friday nights at like 5:30 p.m. So the professors all meet after that class and we do our item analysis to decide if there's any points that we need to give back or if there's any questions that need to be gotten rid of. After that item analysis, I'll push your grades. So look for them around 10 o'clock on Friday night Eastern time. Okay, it's usually pretty late when we release them. Um, I will definitely have them in on Friday night, so you guys don't need to worry about like waiting until Saturday or whatever. But it'll happen on Friday night. It just might be a little bit later than usual. If you after exam one, we always reach out to students who have a KGA under 78%. So if you get an email from me next week sometime, it'll just be that I want to meet with you. I want to talk about like study routine, things that you can do better on for next exam, things that you wish you would have done differently this time around, whatever it may be. If you scored like a really good grade on the exam, but your KGA is still under 78%, I will still be reaching out to you just because I want to touch base before we get into like more quizzes and more tests and all that stuff. Okay. So be on the lookout for that if you fall under that category. Um, if I do email you, it would be in your best interest to meet with me. It's not mandatory by any means. You never have to meet with me. But we can set up like a routine time to like get together and look at stuff. And I think it's pretty beneficial to go over that with me individually one on one if you need it. Okay. Let's go ahead. Let me get my Zoom here. Okay, I'm gonna pull up Canvas because there's some stuff that I want us to go through in there. The one thing I also do want to say is if you guys during the semester can remember to continuously check if I've made comments on your submission in the grade book. I think that would be really beneficial because there were a couple people this past week who submitted their NCLEX questions and they were a little incorrect. And this is the first time you guys have had this assignment, so I don't take points off and I don't give you zeros. I just give you the opportunity to redo them. Okay. So, please like check through the grade book later. If you have a grade in there that doesn't make sense, read my comment that's attached to it and then reach out to me and I'm not going to be like taking late penalties or stuff or anything for those first round of NCLEX questions. But throughout the semester, just know that that's where I'm going to be putting my comments on any of the things that you guys submit. Okay? All right. Mhm. Pull this up. Okay. So looking at our Canvas for this week, We already did our exam. You guys have discussion number two that's due this week. So that initial post that you make has to be submitted by tonight at midnight to receive full credit for the assignment. You have to have a separate post that is submitted for two of your follow-up comments on your peers, and that is due by Sunday night. Okay. Um, you also have this postpartum hemorrhage sim chart. All of you so far have been like really on top of your sim charts, so that's great. Keep doing that. That'll be due by Sunday night as well. Sometimes there is some confusion because if you're looking at it in a different like time zone, like in my, I have to account for like the differences in time whenever I put it into my Canvas. So if you guys see a due date of 02:59 on Monday morning, it's midnight for yours for on Sunday night because my Canvas is in Pacific time or what? Yeah, Pacific time. So if you see that, it just know that it is due Monday night at midnight on Sunday. Sunday night at midnight, sorry. Next week, we have our third quiz. Okay. That is going to cover content on this week, is going to cover content on next week. Okay. So make sure that you're watching the recorded lectures and make sure that you're taking good notes and that you're working ahead a little bit on the content. Okay. I know that you guys were spending a lot of your time studying. So watching recorded lecture for this week or next week is not at the top of your priority list. So, whenever you can, in order to prepare for the quiz next week, watch the recorded lecture and also take some notes, okay? So that's what we have going on this week. That's what we have going on next week. The other thing I wanted to mention, because I had a lot of students, whenever I was helping study for the exam, ask me if it was necessary to come to class and watch the recorded lecture. And I would tell you yes, because the recorded lecture, in case you guys haven't watched any of them, my recorded lectures are at least an hour, if not 2 hours each, because it covers the bulk of the content that you need to know for this class. With my lectures, I'm going into like minute detail and going into the things like in the more like just more thoroughly, right? Class is a time where we are spending reviewing major topics that are covered in each week, but it's not where you're going to get the majority of the material that you need for your exams. Okay. It's going to be good review. It's going to be good for you guys to ask questions. We're going to work on a bunch of stuff together. Next week, we're doing an activity at the beginning of the class, which will be beneficial for you. But if you are looking to get the majority of the information that you need for your exam, you need to watch the recorded lecture and come to class because it's kind of just like they go hand in hand. They complement each other. Okay. So if you have not been doing that, definitely try to do that because that's where most of the content is covered. All right. So, does anyone have any questions before I pull up our PowerPoint for this week and we get into it? Awesome. So, this week, since we're a little bit short, um, if we do not cover everything in this PowerPoint tonight, we're gonna finish out with it next week. Um, when we come back for week 5. Okay. So we're gonna go over everything like that. Whenever we. All right. So let me get this PowerPoint pulled up and we're gonna go ahead and get started. All right, so this week we're talking about postpartum and things that can happen in during postpartum, usually adverse things that can happen after moms deliver. Okay, so first we're going to review from last week. This is going to feel a lot like you're taking your test again. Okay, so just bear with me here. This is going to be good stuff to review even for your HESI exam at the end of the semester. Okay, so how do we measure contractions? Can someone explain that to me? What are the things that we look for when we're measuring contractions?
Like how long they last?
Uh-huh, so that would be what your,
I saw somebody give birth at clinical, and I guess they were measuring like the frequency, the duration, and the intensity of the contractions.
yes, exactly. Yep, that's exactly what you need to do. So here we have the frequency, duration, and our interval, right? Hold on one second. Okay, so our frequency, that's how often our contractions are happening. So, how do we measure the frequency of a contraction? If we are looking at a strip, what are you going to measure from where to where?
From when it begins to when it ends.
So, that is your duration. But yes, that we are going to be measuring that, but that's your duration because that is just the length of one contraction.
Would you say the start of one to the next start of the start of the next one for
Yes,
how far apart they are?
yes, exactly. So, you're looking for your frequency is going to be the start of one contraction to the start of the next contraction. Perfect. Why can we not? How do we measure our strength with palpation? What are the classifications of a contraction, strength wise? That would be your mild, moderate, and strong. Okay. So, like we talked about last week, contractions are the only thing that we do not actually have a numerical value for because we can't get an accurate number unless we have an intrauterine pressure catheter, unless we have that internal monitor. The internal monitor is the only way that we are going to be able to actually get a numerical value for how strong our contractions are. Otherwise, we are relying solely on palpation of those contractions. Okay. So yeah, frequency, duration, palpation, interval, those are the big ones that we're looking for with contractions. What do we want to know? So if a mom comes in and says that her water breaks, what are some things that we're going to ask her about her rupture?
Clarity, like if it was clear or if it was bloody.
Yep. What else
How
would,
much?
yes, how much? That's important. What else?
You got a smell to it
The
or
smell to it?
odor.
Yes. Yeah. Is there an odor? So if a mom comes in and she tells you, my water broke about an hour ago and it was green, what does that mean?
Meconium?
Yeah. So meconium is that baby's first poop. So what if your mom tells you that she has had meconium stained fluid? Where is your mind going as far as how is that baby doing? Like, what does meconium tell us about our baby?
Breathing issues.
It can lead to breathing issues in the postpartum period.
Aspiration?
They can easily aspirate that, yes. If you're thinking about it from like they're not born yet, so they're not breathing just quite yet. Right now, if you know in the womb they've had a bowel movement, what does that kind of tell you?
That they might have swallowed the
Yes.
meconium.
That and mostly it tells us that this baby could be a little bit in distress. Okay. So, all the things you guys were talking about, meconium aspiration, respiratory distress, all that kind of stuff, that happens after the baby is delivered. Meconium fluid in utero, when the baby is still, like mom is still laboring, baby has not been born yet, that is giving us a good indicator of how that baby is doing in the womb at that moment. Okay. So, what that's telling us is at some point in this pregnancy, at some point in this labor, at some point during this whole entire process, that baby was stressed out by some event that caused them to have a bowel movement in utero. Okay. But so like something that I've seen before is if mom has had reoccurring late decelerations where there's placental insufficiency and baby's not getting oxygenated very well, that is a stressful event. So babies sometimes will have meconium and you'll see meconium fluid start after late decelerations. Does that kind of make sense? So meconium can be an indicator of fetal distress in utero. After the baby is born, you guys are spot on. That meconium can lead to meconium aspiration, respiratory distress, metabolic acidosis, hypoxia, all of those things that we do not want from a newborn in the immediate postpartum period. Why is that? Because that meconium is so thick that whenever they pass down through the vaginal canal and their body is adjusting and beginning to compensate and organize itself to be able to adapt to breathing in oxygen and converting carbon dioxide, they're taking that huge big swallow of that thick meconium, and that is going to interfere with the surfactant in their lungs and make it harder for their lungs to fully expand. And they are just going to have a harder time breathing. You'll see respiratory distress with infants who swallow meconium. Okay. So that is why it's so important to know what the color or of the rupture of membranes is, because if you have meconium fluid, you're going to make sure that your pediatrician is at the bedside, right? That your respiratory therapist is at the bedside because they may need more resuscitation after delivery because of that meconium. Okay, so we want to know the color, the odor, the amount, time, and then what is our fetal heart rate tracing doing when the mom has a rupture of membranes? So this is kind of getting your guys' brains thinking a little bit more too, which I know is the last thing you want after an exam, but we're still going to try our best here. Why do we want to know the odor of amniotic fluid?
Maybe like mistaken for like urine, maybe.
So that is not a bad thought. I'm going a little different of a route, but yes, you can sometimes tell if it's pee or not based on the smell of it.
I guess it's an infection.
You said infection?
Yes, ma'am.
Yes, correct. What is the infection of the amniotic fluid called? Do you remember?
It's called the intra. I can't pronounce it.
All right. So our infection of our amniotic fluid is chorioamnionitis. Okay. You know how everybody tells you like C. diff has a very distinct scent. People that you guys who work in healthcare already have smelled C. diff, you know it has a very distinct telltale smell. Choreo is just like that. Like sometimes you can walk into a laboring mom's room and you can say this amniotic fluid, this smells like choreo. Okay. So we want to know that because if mom's amniotic fluid has like a bad odor to it and she has a temperature and she's tachycardic, like we need to start treating her with antibiotics and we need to monitor that baby even closer. Okay. So, another thing that I want to talk about with the amount of fluid. So, why do we want to know? This is kind of going to like our polyhydramnios, our oligohydramnios, having a lot and having a little fluid. Why is it important for us to know if the patient has a lot of fluid or not enough, besides fetal well-being? So, let me ask that differently. What are we worried about if we know a mom has polyhydramnios? She has a lot of fluid, and we have a provider who comes at the bedside, and the baby's head is not well engaged on the cervix. She's got a lot of fluid. She's only 1 centimeter, 2 centimeters, and the provider says the resident, we'll say resident, because they always make these silly mistakes. The resident says, I'm going to break her water. Why would we not want them to do that? She has a lot of fluid. That baby's head is not engaged. What are we worried about?
Because if she doesn't go into active labor and deliver the baby within a certain amount of time of rupturing the membranes, she'd have to have a C-section.
That is a good one, and that is an argument that I've made lots of times, and they don't necessarily care about that, which is not good sometimes, What we're worried about, so think about it from an anatomy standpoint. You have this big, big, bulgy bag of water that when you break it and it goes through just a small opening, that pressure that's coming out it's a lot of pressure when it pops or when it breaks. And your baby's head is floating up here. What else do we have floating around this baby that could come out first?
The umbilical cord.
The umbilical cord. Yes, excellent. So we would have a cord prolapse where that umbilical cord is being delivered before that baby, and that is an immediate C-section. So if you have a resident that comes to your bedside who's like, "Oh, I'm gonna get this mom. This is her third baby. She's 2 centimeters. I'm gonna break her water," and that baby's head's not engaged, and you know she has a history of polyhydramnios, you should be like, "Hold your horses. We don't want a prolapse cord up in here. We're not doing that today." So, knowing all of these things about the rupture of membranes is going to be so important as the bedside nurse because it helps you prepare for how you're going to take care of not only your mom in labor, but the baby once the baby is delivered. Okay? What are our 5 P's that affect labor?
Power, passageway,
Passageway, passenger,
Mm-hmm.
Psychological.
38 seconds.
Position.
Yep. Yep. You guys got them. Passenger, passageway, power, position, psychologic response. What would the nurse do first when noticing abnormal fetal heart rate tracing? Like a late or a variable decel? What would you want to do?
change position.
Bingo, reposition the mom. Yep, because we want to take pressure off of that umbilical cord, right? That's usually what is causing these late or variable decels. All right, what are the 4 stages of labor?
Early labor,
So,
late labor.
stages 1 through 4. So I think you were getting there. You said latent the phase, which is in your first stage of labor.
The first stage would be like dilation of the cervix.
Mm-hmm.
The second stage is like when you're encouraging the different positions.
So your second stage of labor is going to be your delivery of your baby.
Right. And then isn't it the third when like the placenta is delivered?
Yep, your placenta. You got it. What's the last one?
And then is it
Stabilization, postpartum.
Yeah, your recovery. So your fourth stage um, is your recovery period. So your first is your dilation. So that's at the start of contractions until mom's complete. Your second stage is when she's pushing and delivers her baby. The third is the delivery of the placenta. And then the fourth is that first 2 hours after delivery. Okay. A mom is 10 centimeters dilated, pushing, and feeling burning in her vaginal area. Which could the provider administer to decrease sensation to the vagina and perineum as the baby is delivered? Think about your anesthesia. Think about pharmaceutical intervention.
It's not epidural, is it?
It is not. It is, which we didn't hit on this too hard in class. It's a pudendal nerve block, aka sometimes they call it a saddle block, where the provider will take just a bigger needle and go deeper into the musculature so that it numbs the mom completely, usually from like the pelvis area. To be completely honest with you, In all 7 years that I've been a bedside L&D nurse, I have done none of these. So they're not very common because usually if a woman is at 10 centimeters dilated and she's pushing and feeling burning in her vaginal area, that's because the baby is really close to being delivered. And they usually just deliver her and then give her local and then suture any lacerations. But for the purpose of our testing, we need to know that this is an option as well. Okay. Which decelerations indicate uteroplacental insufficiency, and what should the nurse do?
Would it be late
Yep,
and you got to turn her on her side?
yes. And what else would we want to do? There's a couple different interventions that we can try and do with decelerations.
Administer oxygen and increase IV fluid.
Yes. So let's look at this. So yes, our late decelerations are indicative of uteroplacental insufficiency. We have this little mnemonic here, spoilt, that tells us what we should be doing whenever there's late decels or whenever there's an issue with oxygenating our baby. So the first thing we want to do is we want to stop Pitocin. If your mom is having decelerations or your baby is having decels on the monitor and you're giving her something to make her contraction stronger, the first thing you should do is turn off that Pitocin. Okay? Because it doesn't make sense to be actively contributing to the problem, right? So Pitocin is going to be actively contributing to your problem. We need to shut that off. We're going to change her positions. We want to put her probably in that left lateral position. We are going to administer oxygen. Oxygen in L&D is administered by a non-rebreather face mask at 10 liters. We're going to give her an IV fluid bolus because we want to make sure that if she's having low blood pressure, we're treating that. And we also want to ensure that we're perfusing still. Okay. Treat any underlying low blood pressure, administer tocolytics, and then you need to call your doctor. So, in labor and delivery, usually whenever you get an order set, if you have a patient in labor, it has all of these things that you can do already. It has all of your interventions listed. Administer fluid bolus PRN. Turn frequent position changes during labor. And then your Pitocin usually has guidelines that says if your contractions are X, Y, and Z close together, shut it off. Or if your fetus is showing signs of distress, you can stop it. So you already have these existing orders from your doctor. However, if you implement any type of intervention, you need to let your doctor know about it. Okay? Because usually it's because something is happening with your baby, right? So if your baby looks like crap, or your mom's blood pressure tanks, those are things that your physician's going to want to know about because they may need to come and assess her more thoroughly, right? So we need to definitely keep them up to date and keep them posted. What should the nurse do prior to an epidural to decrease the risk of a common complication? So what's our common complication with epidurals?
Hypotension, give fluids first.
Hypotension, and we're going to give fluids. Yes. So, IV fluid bolus to decrease hypotension risk. A lot of anesthesia providers are not going to give your patient an epidural unless you've given them at least 500 mLs of IV fluid first. Okay? That's just to prevent mom's blood pressure from tanking and from baby's heart rate from dropping during the epidural. Name 3 non-pharmacological pain management techniques that the nurse can teach the laboring women to use.
Patterned breathing.
Yep, definitely.
Different positions like squatting.
Yep, position changes. That's great.
Guided imagery.
Yes, definitely.
Aromatherapy.
Aromatherapy. Yep, love it. All these are great. There's literally so many. So massage, touch therapy. I'm not going to try and say that word because I botched it the last class. Ambulation, hydrotherapy, abdominal breathing, modified pace breathing, relaxation, and position changes. Okay. So all of these things are available to our moms, and we need to be able to be knowledgeable on them so that we can help coach them through their labor by using these techniques and by utilizing these uh, this pain management. What symptoms may differ with false labor versus true labor?
With false labor, your contractions stop with like a hot shower or ambulation, position change.
Yes, exactly. So your contractions decrease in intensity and frequency with activity. And then the big one too is that our cervix doesn't change. So even if moms have contractions that stay the same while they're showering or they're up and moving, if there's no cervical dilation or effacement, that woman is not in labor. She's not making any progress. So, but yes, our contractions usually are typically going to decrease in intensity and frequency, or decrease with activity if it's false labor. Awesome. Okay, so that brings us to the end of our review from last week. So let's move on. We have a case study that we're going to work on here just shortly. So the patient is a newly delivered 2 hours post precipitous delivery of a 1.8 kilogram, 4-pound baby girl, which is small. Who can tell me what precipitous delivery means?
Is that where she just like spontaneously delivered the baby?
She goes really fast. So this is a labor typically that is faster than 4 hours from start to finish, would be a precip delivery. So with a precipitous delivery, one of our biggest risks is a hemorrhage because they make change so quickly and that uterus just doesn't know what to do afterwards. Okay, so that's something that we need to know about fast deliveries. Her vital signs have been within normal limits. The OB nurse reports that her fundus is firm at midline and 1 finger breadth below the umbilicus. What kind of a assessment is that? What kind of a fundal check is that? Would that be abnormal, normal?
Wouldn't it be abnormal?
So this here is a normal assessment. So we want our fundus to be firm. We want it to be hard. That means that uterus is contracting nice and very well. If it's at midline, that's good. If a uterus is off to one side or the other, typically that means we're having bladder distension. Her bladder is full and it's making that uterus go off to one side. And then we want it to be at least 1 finger breadth below the umbilicus or somewhere around that range postpartum. Okay, so this right now would be a normal fundal assessment. Her quantitative blood loss is 500 mLs up to this point, and she was a vaginal delivery. What does that tell you? What is our range or what is our normal usually for a vaginal delivery? Do you guys remember those numbers? So I think a lot of this stuff was from our recording for this week. So if you guys were studying, you might not have watched it yet, so that's okay. So our normal vaginal delivery has to be a blood loss of under 500 mLs. Um, a C-section, you're looking at a blood loss of under 1,000. So she was a vaginal delivery, and her blood loss is already up to 500. So she's bled kind of a lot already, especially for her being like 2 hours postpartum. Okay. The patient's peripad was changed 10 minutes ago with a moderate amount of lochia rubra. The oncoming nurse enters the room and the patient states, I feel so cold and tired, I just felt a gush down there. Okay. So we're going to talk about what would we see, what is concerning, and versus what is not. So, what are some normal findings after a mom has delivered? Like, what do we want to see? What do we want our fundus to be like? Like, what characteristics of a fundus are we looking for? It kind of aligns with that assessment that we just had. So we want, let's see. So we went over our blood loss. We want our blood loss to be less than 500 for vaginal delivery and then 1,000 for C-section. And we want a firm fundus. So we want to be able to feel that mom's uterus and we want it to be really hard. Okay? Some things that would be concerning in the fourth stage. If mom is bleeding more than 1 pad an hour, that would be a cause for concern. If she's having any large clots or a lot of small clots that are coming out whenever you're doing a fundal exam. If she's showing signs of uterine atony, so her fundus is boggy, so you'd push on it and it was like, it would feel kind of like, I don't know, like mushy.
Spongy?
Yeah, a little bit. Yeah, it feels weird. Like it's definitely soft. Like you can indent it really, really easily. So that would be like what a boggy fundus would feel like. Signs of an unrepaired laceration. So we talk about this because this can be a source of bleeding that oftentimes goes overlooked. So if you're performing a fundal exam and you're rubbing this mom's belly, you're rubbing her uterus, and it's nice and firm. She doesn't have any large clots coming out. Her fundus is midline. That's all normal. But she still has like a gush of blood with every time you press down on her stomach. Most of the time, it's because it's an unrepaired laceration that needs to be assessed by a physician. Okay. So, your signs of an unrepaired laceration would be a constant trickle of blood from the vagina while your fundus is firm. Okay. So, we would need to make note of that for sure. We also want to look for signs of a hematoma, which is that intense perineal pain. Mom would have a lot of swelling. There would be a blue-black discoloration, all of that kind of stuff, okay? And then obviously, like if mom is losing a lot of blood, she's going to start showing you signs of hypovolemic shock. So she's going to be dizzy, lightheaded. Her blood pressure is going to be super low. Her heart rate's going to be high. She's going to be confused, super pale, not having very much urine output, if any, and then cool and clammy skin. Okay? All of these things would be concerning findings in the fourth stage. All of these things could indicate that there's something going wrong with mom and it's an underlying cause for concern. Okay? Then there's this really scary picture that I don't like. All right, so if you are at your bedside and you're assessing your mom, you feel her fundus, it's super boggy, it's like not firming up really well, and she's throwing a bunch of clots. Okay? What is your priority? What do we want to do? If your mom's bleeding, what do we want to do?
Notify the provider?
We want to stop our bleed. Yeah. So the first thing is we need to figure out where is this blood coming from? Okay. We have to consider the cause. We need to always assume that it's coming from the uterus until proven otherwise, because that is the bigger problem. Okay. An unrepaired laceration, while it is going to cause some bleeding, does not typically cause the amount of bleeding that a fundal, an issue with the fundus is going to cause us. Okay, so we need to consider what is the cause. Assume it's atony unless it's proven otherwise. And then obviously, like, how do we know that we fixed the problem? I promise it's not a trick question.
When you press on, right? She won't bleed.
Yeah, she's not going to bleed anymore. If we fix the problem, she's going to be done bleeding. Okay, so some things that we need to take into consideration when we are assessing for the cause and we are looking for the underlying cause of a bleed. Fundus. We need to feel her fundus. Who can tell me how to perform a fundal exam or a fundal massage? Because that's important. We need to know how to do it. Women who've had babies, you probably just remember that it was not very fun.
Isn't it where they like cup underneath the bottom of the belly and push up a little bit and push down near the belly button?
Yeah, so you're literally just feeling that mom's fundus with your hands. Okay, so one of your hands is going to be at the top of the fundus. The other hand is going to be at the bottom of the fundus. Why do we want this hand at the bottom?
To keep it in place.
To keep it in place. Sometimes, depending on how many kids a woman has had, depending on her anatomy, depending on her history, if you don't have that hand and you push down really hard, you can completely invert that uterus. Okay? It's not common, it's very rare, but it can happen. Okay? So we hold our hand down there to support. We want to provide that support for the fundus. The other thing, too, is like think about it as like you're sandwiching that uterus in between your two hands. You're adding to the contractility of this motion as you're providing the fundal massage to firm up that fundus faster and more effectively. Okay? So, one hand on the top of the fundus, one hand at the base of the fundus. You're providing that good massage, excuse me. As you're doing that, you're going to see and you're going to be examining her perineum because you're going to look for her bleeding, if she has any clots that are coming out. How big are the clots that are coming out? Did you have a question, Jania?
Yes, I wanted to ask this before I forget. I don't mean to change the subject, but
No, you're fine.
earlier uh, for a natural birth is like 500 and below, and then a C-section is like 1,000 and below. Now, I saw a patient at clinical give birth, and I also saw a C-section. Now, I didn't stay for the whole thing for the C-section, but I realized they were using this tool. It's kind of like it burns the skin. They were not using the normal regular,
Cautery?
right. They were using this skin and it was this thing, sorry, and it was burning the skin basically. So there was like little to no bleeding.
Yeah,
So I was trying to figure out, I thought the number for the C-section would be lower than the vaginal birth because when I saw the vaginal birth, she bled like a lot. So
yeah.
I guess I was trying to figure out how, or is that just for the traditional cutter or that's just the number
Um,
for,
so that's a really good question.
because
Because you can see, like, there are sometimes I'm in a C-section and the mom's total EBL is only 150, right? And then there's other times I'm in a vaginal delivery and the mom's EBL is like 400. Okay. So it really is dependent on the patient and the surgeon and just the procedure itself. But in general, anytime you're making a surgical incision, you are going to have a lot more blood loss because you're cutting through tissue. And oftentimes, those providers have like a suction machine, they have suction up at the field. So they're suctioning up the blood as it's coming out. So usually they look at that suction machine and it tells them how much blood that the mom has lost, which is where a lot of it is like brought into play. But that's a really good question because there are some times where a vaginal delivery can have more bleeding than a C-section, and neither one of them are abnormal. It just depends. But that's cool you got to see both a C-section and a vaginal delivery in your clinical. You're a lucky one, I feel like. Um, all right, so we talked about our fundal massage, we've talked about our fundal assessment. Okay. Why is it important for us to consider putting in a Foley? Let's think about it from an anatomy standpoint, right? We have this safety thing. If she's bleeding, obviously, we're not going to be like, let's take a walk to the bathroom, unless you want your patient to be passed out on you on the floor. Think about where your uterus lies in relation to your bladder. So, you're your uterus, and it's trying to clamp down, it's trying to clamp down, and this mom is a vaginal delivery. She hasn't gotten up to pee since she's gotten here in labor, and she was in labor for 3.5 hours, and we've been giving her fluid the entire time. You feel her fundus, and that fundus is displaced. It's moved off to the side because her bladder is so big and full, right? If her bladder is full, it's going to be pushing up on that uterus. It's going to be pushing on that uterus, and it's going to completely displace your uterus. Your uterus is going to be like here on your mom, all the way over to one side. So we need to we need to make sure that her bladder is empty and that she is adequately voiding, because a full bladder is going to cause that uterus to be displaced, and it's not going to allow for that uterus to fully clamp down. So you're ultimately going to have a boggy fundus, and you're going to have more bleeding, all because that bladder is in the way. Okay, does that make sense? Thinking about it like that. Your bladder's in the way. It's causing your fundus to move, and it's gonna have a hard time clamping down, and we're gonna have more bleeding. This oftentimes can happen a little bit later after delivery. So, for example, I had a delivery one time where I was taking care of a mom postpartum, and she was probably 8 to 12 hours postpartum. And all of a sudden, she just started throwing clots and bleeding and bleeding and bleeding. And her fundus was super boggy. And I asked her, like, if she had gone to the bathroom, because when I was doing her fundal assessment, it was displaced all the way over to her right side. And she had not been up to pee since her delivery, which had happened, I think, overnight, and I was coming in the morning. So I straight catheter with like a red robin and pulled off 1,500 from her bladder. And then, what do you know? She didn't have any more bleeding. Her fundus was perfectly midline. All of her problems went away. We went about the day happy as clams, and that's all we had to do. But whenever you have like a full bladder, it really can impact the amount of bleeding you have and whether or not that uterus is able to close down. Okay? What about Pitocin? Why are we going to want to give Pitocin after delivery?
Is that so that the uterus contracts and gets back down to its normal size?
Exactly. Yep. So Pitocin is something that your body's going to produce naturally. Pitocin is going to cause that uterus to contract further. It's going to help bring that uterus back to its pregnancy size. So after delivery, we usually give a bolus of Pitocin in some way, shape, or form. Typically, it's 20 units in a 500 ml bag of LR. It's typically how we do it. But Pitocin is basically just making sure that uterus is able to contract, and it's going to minimize the amount of bleeding that we're seeing. Okay? So, are things that we also want to do. We're going to massage that fundus. You guys are going to hear me say that like probably 10 more times when we talk about this PowerPoint. Massage that fundus. Make sure it stays nice and firm. Manage the bladder. Any medication, so uterotonics, these meds you guys will need to know for sure. Okay, we talked about our Pitocin, we talked about why that's important. Methergin is another medication. It's another uterotonic that we can administer to have more effective contractions in the postpartum period and allow for that bleeding to be minimal. When is Methergin contraindicated? What patient would we not want to give Methergin to?
Hypertensive.
Yes, a hypertensive patient. Excellent. Anyone that has high blood pressure, we should not be giving Methergin to, because one of the side effects of Methergin is an elevated blood pressure. Okay. Misoprostol or Cytotec is a med that we can give in the postpartum period. We usually give it 1,000 micrograms rectally immediately after delivery. Cytotec is a medication that can cause moms to have really bad pain, postpartum pains, so like a lot of contractions, because Cytotec basically just increases the contractility of our uterus, which is what all of these uterotonics are doing, but it does it to a point where the moms can sometimes complain of some discomfort, and they may need some medication to help with them, okay, with the cramps. Hemabate is our last one that we're going to talk about, and when is that one contraindicated?
Asthmatics.
Yes, if a patient has asthma, we cannot give a patient Hemabate if they have asthma. Okay, because you have that constriction of the vessels, it can sometimes cause bronchial constriction and lead to an asthmatic attack. Okay, so we do not want to give an asthmatic patient Hemabate. You guys will definitely need to know that for your exam. Okay, these four medications here that we have listed, they are talked about more extensively. I talk about them a lot more in the recorded lecture, And we also have like a huge table. I forget what page it's on. I'm not going to be remember off the top of my head. There's a big text page in your textbook that has all these medications listed in a table for their uses, their contraindications, their dosage, all of that. So if you can review that on your own, I think that will be beneficial for you. Um, yeah, so definitely know the when Methergin or Hemabate are contraindicated. Okay. Obviously, if your mom is bleeding, we need to have a 2 large bore IV access. Okay. Because we most likely are going to have to give blood, right? And blood is not compatible with anything except saline. So we need to have 2 large bore IV accesses. It is not going to be easy for you to find an IV on a mom who is hemorrhaging. Okay, so protect the one that you have and then try your best to get a second one because you might need to use it in an emergency. We're going to monitor her vital signs. Her vital signs are going to be a really good indicator of whether or not this mom is still being or still having adequate perfusion, right? If she remains hypotensive, she remains not alert and oriented, her respiratory rate is decreasing, her heart rate is still staying increased, we can assume that this mom is still hemorrhaging and there's still an underlying cause for concern, okay? If her vital signs start to level out, we can rest a little bit easier. We don't fully take our foot off the brake just quite yet, but we need to monitor her very closely. Every time I've had a serious postpartum hemorrhage, I'm getting this mom's blood pressure like every 2 to 5 minutes. Like, because if you're having somebody at the bedside performing continuous fundal massage, you have another person looking for an extra IV access, you have a third person who's administering oxygen, running your fluids. You need to be able to run and help grab things, especially in the case of an emergency. Postpartum hemorrhages, guys, can go from 0 to you're going back to the OR and this woman is at the risk for having a hysterectomy. Like within 20 minutes, I've seen that happen. So that's why it's so important when we talk about our postpartum assessment because they can escalate and things can get out of control really quick. Okay. Obviously, we're going to be giving a lot of IV fluid and blood products, potentially some other volume expanders if the provider deems it necessary, because we need to maintain our tissue perfusion. And like we said at the beginning, we know it worked if mom stops bleeding. Her vital signs improve and her fundus is nice and firm. Okay? So we're going to stop here for tonight. We are out of time. Next week, we're going to continue with this PowerPoint. We're going to finish up this PowerPoint. We're going to do a little classroom activity after that one, and then work on our week 5 classroom PowerPoint to finish up. Okay. You guys all did awesome. Your exams will be posted on Friday. If you have any questions in the meantime, please don't hesitate to reach out. Thank you so much, and I hope you guys have a great rest of your week. See ya.